Hello, my name is Samuel Shor, Associate Clinical Professor at George Washington University and a preceptor in the Precepting Clinician Program for ILADS, the International Lyme and Associated Disease Society. It's a program for which we hope to expand the ability of clinicians in the community to be able to manage the, at times, very complex conditions we call chronic Lyme disease. I became interested soon after going into practice in fatigue and chronic fatigue and what ultimately became characterized as chronic fatigue syndrome. And slowly through my interest in cultivating my ability to manage my patients with chronic fatigue, I became involved and intrigued in a potential connection of Lyme disease being responsible for chronic fatigue, and subsequently published a paper in 2011 that I believe provided evidence to support that the majority of my patients with chronic fatigue syndrome actually had blood test negative Lyme disease, and that the majority of these patients responded to antibiotics. And in assessing the therapeutic response that these folks had, where previously they had not adequately responded to other types of intervention, but had profound benefits to antibiotic intervention, I was compelled to publish that paper, and that's how I've gotten involved in this arena. Primarily an entrenched belief system that has been perpetuated by large organizations that are involved in providing guidelines for this condition that I believe have not been adequately open to the literature and new evidence, such as the article about which I just referred that was published in peer review, and that these belief systems have unfortunately provided too much restriction in relation to patient access to management and oversight in clinicians who believe that this chronic condition exists, as do I and many others. I think of in one of my patients who is a sentinel patient in relation to chronic fatigue syndrome and Lyme disease connection. It was a 42-year-old gentleman, was a lawyer on disability, wanted to work, could not work, was on disability for at least a year or two before I started seeing him. And it was soon into my connection between chronic fatigue and Lyme disease. And after inquiring that fact that he did spend much time outdoors, he lived in the Lyme endemic Northern Virginia area, I began inquiring, investigating additional testing, and started treating him accordingly. And this was a gentleman, again, who was 42, very hard worker, wanted to go back to work, but just couldn't. Started him on antimicrobials, antibiotics of different types, followed him very closely, adjusted according to his clinical responses, and after 15 months of very carefully supervised management, he ended up going back to work full-time and is still working full-time. And he was one of my many patients about whom I had published in that paper. So this was a very important case for me, which solidified my belief that this entity was real and that there were many people who were hurting and needed more clinicians to be aware of how to manage their very often complex conditions. The ability for us to reach out and to help more people. This is a very complex condition which often is multi-systemic, meaning that many systems in the body are involved, the nervous system, the cardiovascular system, the immune system, and that it is not well understood, and there are a group of clinicians who, through experience and through interchange of ideas and sharing of anecdotal responses of their patients, that have evolved approaches to dealing with patients that have been fairly successful, as I alluded to in my case as well. And we're constantly sharing ideas. This is a process in evolution, but it's my perspective, as is others in this program, that the more clinicians we can teach and share our insights, the more they can teach others, and more importantly, be able to help a wider variety, numbers of patients who are in need. There's a sharing response that occurs. I learned from that experience as well, that people who are interested in a particular condition bring to the process their own personal experiences and insights, and can provide the mentor with additional insights as well that I can then bring to bear treating my patients and in fact precepting other clinicians as well. What inspires me, having the insights to managing these very complex conditions where there are very few clinicians in the community who either have the interest or the ability to manage, let alone to see consistently positive outcomes in the vast majority of our patients who present with, as we indicated earlier, multi-system issues, fractured sleep, chronic fatigue, cognitive impairment, mood disorders, autonomic blood pressure abnormalities, and being able to pull it all together and to be able to sit at the point of care and improve outcomes. It is particularly gratifying when patients have been bandied about from physician to physician, either being told that the clinician didn't know what to do, or even in a more negative approach, downplaying what their conditions were and minimizing the very disabling conditions with which they were presenting. And to be able to provide hope and real benefit to improve outcomes in these patients has been exceedingly gratifying. For more information about the Physician Precepting Program, visit www.ilads.org. Thank you.